Good evening. Welcome to the EASL Studio, your weekly pathology broadcast news. In today's episode, we will discuss why bother with diet and exercise when an injection will suffice. A bit provocative topic and a very interesting discussion with two board experts, which I'm happy to present as our faculty for this evening. Professor Giulio Marchesini, which is a professor of medicine from the University of Bologna, from the unit of metabolic disease and clinical dietetics, is an expert in NAFLD, a well-established and known, I don't need to present you much, Giulio, expert in diabetology, nutrition, gastroenterology. So very happy to have you with us. And the second guest is Professor Riccardo, Dalle, which is the director of the Department of Eating and Weight Disorders at Villa Garda Hospital in Verona. He has developed actually an inpatient treatment program for eating disorders based mainly on cognitive behavior therapy. So we are looking forward to hear about it in this session. I welcome the both of you. And I would like to start from the beginning, really, with the question that always bothers me. You have a patient with NAFLD or muscle, should we say, and obesity. He enters your clinic. And now you want to discuss weight reduction, you want to discuss dietary modification. How do you start the discussion? How do you know that he really wants you to discuss about it? We will start with Riccardo.
Thank you. First of all, thank you for the nice invitation. I appreciate a lot. It's a difficult question because there is not a definitive approach with a patient because we have to consider many factors. First of all, I think is the reason for the patient visit. The second is if it's a new patient or a patient that we know, and also the overall health status of the patient. For example, if a patient, I think the reason for the patient visits should be addressed first, even if it is not related to the body weight. And only after that we have addressed the reason, we can introduce with be cautious and empathy the topic of body weight. Maybe asking, for example, if are you comfortable discussing your general health care issue such as weight? It's different if the health status of a patient is strictly related to the body weight, and such as, for example, now for diabetes type 2 or hypertension, and so it is possible also to ask a general question like, for example, do you think that your weight is influencing your health problem? Do you have any concern about your body weight? And also, we have also to take in consideration the culture, the age, the health literacy of the patient, because clinical skills are very important. But we have always to think that body weight is a very hot topic, and we have to make our best to avoid any approach that can stigmatize the patient.
Absolutely. And which answer of the patient would make you happy? What would you like to hear from him that you will know that you got permission to start discussing his weight?
Yeah, if a patient, most of the patient, if you address the topic with empathy, they like a doctor that is interested to the health status, and also if we ask if they like to have a discussion on education or relationship between body weight and the health status, most of the patients are happy to discuss this. Okay.
Yeah, I feel the same. With empathy and good connection with the patient, you feel that you can move forward and discuss it with them. Giulio?
Riccardo, may I ask you a question? What about the history of body weight, which is extremely relevant, and it depends on what...
There are many things that we have to consider, because most of the patients have been stigmatized for the body weight, especially by health providers. In the past, you know, the weight stigma was prevalent among physicians. Okay, so and this in some patients has what we call the internalization of weight stigma. This means that they agree on the label that the weight stigma attribute to the patient with obesity. So they think that it's their fault to have a higher body weight. They have very low self-efficacy, so they are afraid also to address the topic sometimes of the body weight, because they are afraid not be able to address the obesity. So the history of the previous failure in the treatment of obesity and with the previous experience with the therapist, I think is very important, and also have a big influence in the discussion and in how we address and how the patient respond to our questions.
Very interesting. Giulio, do you use motivational interview?
Yes, usually we try to make some sort of motivational interview, starting from the balance of pros and cons. If we have, after we have agreed about the importance of body weight, obviously, and we try to evaluate the pros and cons of weight loss, and also the possible discrepancy between what people think they have to do and what people think they can attain. And this is possibly one of the main reasons why they tend sometimes to stop their weight loss program. And also another point very relevant is self-esteem. And a question is that I always ask, if we come into the area of body weight and we decide that there is some need of body weight loss, that is, they have to lose weight.
Is an interaction.
Yeah, a little bit. Maybe Riccardo, in the meantime, you can tell us, you can define what is actually motivational interview. Maybe not everybody knows exactly what it means.
I think that is a complex approach that we can just adapt to the context where we work. For example, in a classical internal medicine context or primary care context, I think we have to take some adaptation. Okay? As Giulio discussed, we have to ask directly about the pros and cons to address the I don't say body weight, but the obesity and the health related to the obesity, but also the readiness. Are you ready to start? For example, I realized that a simple question like how much are you ready from 1 to 10, for example, and the answer can, for example, if a patient say from 4 to 6, maybe it's not just ready, it's very, or 4 to 6 to 8 is ambivalent. Okay, and so we can ask something about the ambivalence, and I think I don't know what Giulio was discussing about self-esteem and self-efficacy, because this is a very, very important psychological construct that can influence the motivation. Because
absolutely. So just to be sure that everybody understands, in the motivational interview, you ask open questions, right?
Yeah.
You guide the patients, but you actually give them a lot of space to respond in
So
motivational
there are
interview,
also
right?
some important aspect, not to be directive but collaborative. This is difficult for the doctors usually.
Right.
We are used to do this. We prescribe the change, okay, because we think it's good for the patient, but it's not always true for the patient. This from the point of view. And also to have the patient to feel in control, to feel in control needs that we have to do to be sure that the patient decide to address or not the change, not to be imposed the change.
That's
This is
great.
crucial for the engagement.
Yes, it's very difficult to do. It's a very something that physicians, caregiver need really to learn how to do it. It's not obvious.
We are not used because we are used to treat especially acute disease. We are very good in doing diagnosis and after to prescribe the solution. But with chronic disease, which require an active role of the patient and a long-term change, especially on lifestyle, it is clear that we have to change the approach.
Absolutely. Giulio, would you like to complete what you started to say?
Oh, no, simply that it's very difficult to engage patients. And one of the reasons I try to ask to use is that if I can understand what are the goals they are aiming to, it's much easier that I can in some way help them to reach those goals. And this is also important because sometimes the patient have very
Unrealistic
hard goals to reach, and
yes.
It's quite impossible. And but we must be aware that we must be very careful when we try to motivate patients, because if they drive for very hard outcomes, this might be a reason for failure, for total failure.
Absolutely. Setting realistic goals together with the patients in a shared discussion is so important. Also, you mentioned a couple of times the self-efficacy issue. If you set goals that are unrealistic, it really kills your self-efficacy, right?
Yes.
There is something that we have always to remember when we have to work on behavioral change. First, never ask something to the patient that they do not see as a problem to address, because we don't start. And never ask the patient something that they are not able to do. Okay, because in this, I teach always this to my colleague, because sometimes we underestimate we think that it is clear that this is a problem for the patient, and sometimes we ask something too difficult for the patient. Okay, so empathy is not just the relationship, but to understand the patient. Okay, what are the goals, the expectation, and also the resources, because sometimes in medicine we work only on the deficit of a patient, but sometimes it is important also to see what are the resources of a patient in changing, and also around the patient, the family where the patient lives, and we have to stress these resources, and sometimes we don't do this.
I wanted to ask you, do you involve family members? Do you find it helpful to involve the family? Because I say sometimes to the patients, please, next time, if you agree, of course, please bring your family with you. I would like to meet them and have some discussion with them.
I think Giulio can answer, because
yes, we usually try to involve family members. It varies. For example, if you are dealing with a woman it's probably not so important because they can have resources by themselves. For example, they are more apt to use or to engage in culinary activities, and so they are more able to stay in some way in a sort of dietary plan. With males, it gets much more difficult, and sometimes we use to involve women, and this is which should be balanced against the possibility that the family members are a resource, and sometimes, on the contrary, they go the opposite way. And so,
Right.
if this is the case, it's very difficult for people who live in a family try to lose weight.
Yes, I always tell them they need to change the house. It's not changing the diet of one person in the house. They need to
Yes,
change the
but
house.
we have also some experiences since we measured, for example, some times ago, the weight and the type of meals that in those of physical activity of family members in people who were engaged in group-based behavioral therapy. And at the end of the program, also the family members changed something in their behavior.
Yes,
This is very interesting study, this, in my opinion, because, and on the contrary, the patient that were not able to change, also the family member didn't change. So there is an interaction you need. And so I think that we have, if it is possible, you know, the inclusion of the family member is crucial. We learned this from the study of child obesity, that the family member play an important role, and maybe we missed the inclusion of a family member in treating the adult. I think that there are two main strategies. One is to help the family member to understand the obesity in a different way, because the education, they don't know. The stigma is also in the family sometimes, and also to involve how to create an optimal family environment to do a behavioral change. This is not easy, but it's possible. The second, for some patients, but not all the patients, some patients that agree we can involve a family member in helping the patient to implement some strategies to address the behavioral change, but with the agreement of the patient, of course.
Of course. It starts with what you buy to the house, actually, right? I mean, sometimes I go over what they buy in the supermarket with them. We go over the list of the family shopping list. I think it starts with the smallest things, but also with behavioral issues and the relationship within the family.
But also for physical activity, that is true, since it's much more convenient and much more interesting to make physical activity in groups than alone. So it's really important to have family members involved.
Absolutely. Riccardo, you wanted to add something?
No, I agree completely. It is clear that we have to create a change in the environment of the family, because it's difficult otherwise to change. But also, I think we have to involve the family member in changing the communication about healthy lifestyles, exercise, have a different also opinion, a way of thinking about obesity as a chronic disease that is not the fault of an individual. Okay, and this is one of the difficult for some family member. It is difficult to understand this, because with the bias, the weight bias is within the family. Okay,
it's so true, so true.
So, for example, I prepare some educational video for family member. The first video is to give education of a new way of thinking about obesity. And then we did another video how to create an optimal family environment. And also the third video is discussing about some behavioral procedures to help the patient to change. Okay, but the first video, education on obesity and in general metabolic disease is crucial in my opinion.
I agree. I would love to see these videos. I mean, just explaining that it's not an individual, there's no guilt anyway. There's
Because
no guilt in
we
being
don't
obese.
educate, we don't change the attitude and the behaviors. Okay, sometimes some dysfunctional attitude and behaviors are related to the fact that we don't know the obesity and the chronicity of the genetic component and the biological component of obesity.
Right. I wanted to move a little bit forward and ask you a difficult question. We know that weight reduction is so difficult to achieve and so difficult to maintain. Does it worth the effort? Eventually, you know, people lose weight and gain weight, they lose weight, and eventually maybe they keep a few kilograms, let's say like 5 kilograms of weight reduction eventually. Does it worth all the efforts? And then the provocative question, why not just use medication? You have injection now and it seems like a magic bullet. What is your take on that?
For sure, now we have drugs which are very active. And this means that in some way it's quite easy to lose weight with drugs, and to an extent which was absolutely unbelievable up to a few years ago. And but in my opinion, a correct educational or behavioral approach is still worth. And this is the same for people who are engaged into bariatric surgery. And we have groups of people that are taught how to manage also after they have succeeded with bariatric surgery. And this is something which may prevent weight regain after bariatric surgery. And we now know that drugs are effective as long as they are used, but as soon as you stop drugs, weight regain is invariably occurring. And this is the one strong reason to engage patients also after weight loss achieved by drugs, to engage into some sort of behavioral therapy. Probably it might be not as intense or as sustained as it is in people who do not have drugs aboard. But in some way, I think it's definitely mandatory. By the way, we don't know exactly what these drugs are likely to do in the very long run, for example. But anyway, they seem safe. And I believe they are reasonably safe, but they are drugs nonetheless. So I think that if we can achieve a little bit of weight loss by behavioral therapy, it is definitely worth of it.
Thank you, Riccardo.
Okay. I completely agree with Giulio. There are many reasons. I think that Giulio described very well. However, I have to underline that if we look at the study of the STEP study trial of a sormon with semaglutide or sormon trial with terzepatide, they always associate the drugs with lifestyle modification. So, and also we moderate caloric restriction and moderate activity. We have also, in my opinion, not to forget that the healthy lifestyle, healthy dietary pattern like the Mediterranean diet or a good physical fitness is associated with reduction in mortality and cardiovascular disease without any weight loss. And also regular physical activity reduce the loss of fat-free mass. So there are many reasons. The last, I think, is very important, as Giulio underlined, that behavioral approach on lifestyle modification can increase the adherence also of the patient to the drugs. In real world, studies, the attrition from these drugs, at least in people with diabetes, is very high, about 50%. And in the past also, we know that using behavioral approach reduce the rate of depression, improve the quality of life of a patient. So I think that now we have to say that lifestyle modification must be always associated with drugs. Drugs must be always associated with drugs, maybe with lower intensity as in the past, because the drugs can help to adhere more to the lifestyle modification.
That's great, and I'm really happy.
Also another reason, that is cost, by the way. I'm not sure that the national health systems can reasonably support.
Yeah, everybody wants these drugs, right?
Yeah, but this is another question.
Yeah, I also like, Giulio, that you described the association, the experience with bariatric surgery, because I remember more than 25 years ago that in a national conference of the Obesity Society, a very famous bariatric surgeon come and say, you have to change your work, because with bariatric surgery we resolve the problem of obesity. And now they realize that the work on lifestyle modification, psychological, mechanisms associated are crucial. And in some way, they are more advanced in associating lifestyle modification and psychological counseling than some medical society on obesity. Okay, I have to say that now I are so enthusiastic about the new drugs. It seems that all the things that we know about the lifestyle modification and psychological mechanisms associated with obesity are not so important.
Yes, it's really always important to emphasize that although the drugs are so effective, and we're really happy to have them finally, lifestyle modification and behavioral therapy always need to accompany this treatment. And also, I'm very happy that you mentioned, Riccardo, the importance of dietary composition to general health beyond weight reduction. It's really something important to remember. We are almost finishing the session, and I have a very important last question to the both of you. So let's finalize in a positive manner. What are the 3 best tips, advice you can give a physician or a caregiver in the treatment of the NAFLD patient or obese patient?
If I have to start, I think that from a hepatological point of view, the hepatologists cannot, definitely, they are not prepared, let us say. They are not prepared to engage in behavioral therapy. And this is the reason why one of my main issues and one of my main attempts was to create some sort of connections between the EASL and the ESD and the EASL associations, because people who engage in the therapy of diabetes and in the treatment of subjects with obesity are possibly much more aware of the difficulties of behavioral therapy, and also are much more prepared to engage in solid programs of weight loss than the hepatologist. I think this
Giulio, you need to take over. Thank you. Please take over. Yes, Riccardo.
I want to underline what Giulio explained very well. I think it is crucial to not just to medicalize the approach. We are lucky now, but we have new drugs that open new scenario and hope for the patient. But we have not to forget all the study that we made on lifestyle modification, the role of the patient, active role, the collaborative approach, and also to help the patient to understand that obesity, metabolic disease are chronic, non-communicable disease, but their role is very important. The active role of the patient in developing a collaborative approach with the doctors, and also the lifestyle modification, this group is crucial to obtain long-term result.
Well, Riccardo, we are just finished our time, but there is possibly a lot of there are possibly a lot of things which should be discussed, and the problem of the new classification, for example, I'm not sure that the new classification is of great help. And the new classification, which moves from NAFLD to MASLD or steatotic liver disease. But my idea is that this classification may help to engage or to create some sort of connections with other societies. Do you believe that this might be the case, since as I told you, as I said, this is something which is probably the most important issue for the treatment of NAFLD?
Yeah, I think it is crucial. It is clear that there is an interaction, metabolic interaction between all these metabolic complication. And one of the problems that the society and especially didn't speak to each other, okay? And what it is clear, maybe the new drugs can help also to create an interaction between specialty in obesity, diabetes, hepatic problem, but also cardiologists, because it seems that there are underlying biological mechanisms that link together this metabolic and disease. I have also to underline, because this is my work, that an interaction is also the lifestyle, how we eat, how we exercise, and so it's not just a biological mechanism, but it's an interaction of several factors that interact together.
Yes, Shira has come back, so just in time to...
Yes.
It was some sort of very difficult connections. I had a default beforehand, and she had to move outside for a while. And anyway, I think we can conclude meeting.
I think it was
Shira,
a great discussion, and I'm going to watch the recording to listen to the last 2-3 minutes. So thank you both so much for joining us this evening. It was fascinating. And I will just say what we have next week. So next week there will be a replay of an episode in which the speakers shed some light on the topic of albumin and cirrhosis. And as always, remember to become an EASL member and join the EASL family. Thank you both very much, and have a nice evening.
All my best to all of you. Bye-bye. Hi,
you.
Shira. Hi, Riccardo.